I think that we just mentioned about romidepsin, and we were talking about single agent, but very exciting that there are actually several trials that are either in recruitment or underway to assess the safety and efficacy of romidepsin, actually with combinations. And some of these are a phase 3 trial of romidepsin CHOP, and basically versus CHOP alone in patients with previously untreated PTCL. We won't get into the debate whether CHOP is a good standard therapy for PTCL. That's been a long debate, but it's at least something to compare to. Another one is a phase 2 study of gemcitabine plus romidepsin and relapse refractory PTCL. Another one with an agent that we all know that's active, pralatrexate, but pralatrexate plus romidepsin, and a phase 1 study of romidepsin and ICE in PTCL. And one other interesting one that's a novel agent is alisertib, which is actually an Aurora A kinase inhibitor, and that's a phase 1 study of using that in combination with romidepsin and treating either relapse refractory, either T-cell or B-cell lymphomas. I was wondering, does anybody have any experience from the panel with alisertib, or in case maybe we can ask either Steve or Anas?
I don't have personal experience with this.
We have some experience. So there was a phase 1 from SWOG, and in T-cell lymphomas, 4 of 8 patients or 4 of 7 patients based on evaluability responded. So that started 2 studies. There was a phase 2 led by SWOG, that was an intergroup study that we participated in, which I don't have the final results, so that study is done. What I know is that it passed an early stopping rule, so there's some activity, and then it's completed, and I think that's about a 40-patient study. There's also an ongoing a randomized study against standardly approved agents. So it's an oral drug, alisertib. It's easy to give because it's oral. There is some toxicity, there's some neutropenia, there's a little bit of stomatitis, so it's not an oral drug without toxicity. But one of the exciting things about that is that we're going to have a randomized study comparing it to pralatrexate, romidepsin, or gemcitabine, I think are the 3 investigator choice arms, which at a minimum will increase the level of evidence we have for some of our decisions in T-cell lymphoma. Lauren agrees with me on autotransplant and T-cell, so I thought maybe she'd want to chime in.
Well, thank you. Thank you for the opportunity. So now the scale has shifted over here. I think the problem is that if you look at T-cell lymphomas, they're very chemo responsive, but the duration of response is horrible. And so many of us like to be excited about our responses and want them to continue. And so we consolidate with autotransplantation because we know that for the vast majority of patients, there'll be a rapid relapse. And despite the fact that we have all these new tools, we don't always get to recapture the patient. So yeah, you stand alone on this one, at least at this table.
And actually,
Anas?
I do the same thing that these guys do. We do upfront autotransplant.
I think it's so.
We don't want to gang up on you, but
So I think both are correct. I mean, for the lack of other options, I think transplant would not be wrong to be offered to selected patients. I don't think it's an umbrella approach. I think you'll be exposing more patients. But I think the strategy is really to build on a better induction regimens. I think that's the way out of this. We can't accept transplant as the end, I think, solution here. I think temporary, it will change with time. I think it serves a purpose for the time being for some patients. I'm sure it helps some patients. There's no randomized trials for sure. Do I offer it to some patients? Yes, I offer it to some patients. Do I offer it to all patients? No, I don't offer it to all patients. So I think it's an option, and it has to be weighed against risk and benefit.
I was just going to add maybe to that. I mean, one of the potentially exciting things that could come out of some of these sequencing or other data is targeted therapy, great, but what if we could also identify who of these patients is not going to be cured with standard chemo and who could? I mean, that would end the transplant debate if we said you're in the non-cured group with combination chemo, we take you down to another approach. If we can identify a signature that has a high chance of being cured with standard approaches, I mean, because of course the end is going to be it benefits some, it doesn't benefit others. We just don't know who they are at this point.
PET could be discriminated. You guys done some studies with PET, and you look at romidepsin study PET predictor as a predictor of outcome.
Yeah, this is where I also get nervous about T-cell lymphoma because you feel like we're maybe forever just reinventing the things that were done in diffuse large B-cell lymphoma just 7 years later. Yeah. But the interim PET data is intriguing, and actually if you look at in the romidepsin series, the patients who achieve PET negativity, their median duration of response, I think, is beyond 4 years now. So there is this subset of people, it's the CRs, but it's really the PET negative CRs, not the CR by CT criteria, which was the primary endpoint of the study. And those patients have had really durable benefits. So Again, we're always dealing with small numbers, and if a large randomized study was done, maybe it wouldn't show it. But there is this recurrent theme in T-cell lymphomas that the PET negative ones have durability, and when we see residual disease, like Lauren said, the duration is poor, they respond, and then they grow back quickly.